Want to thank Matt Schuba, one of our distinguished faculty, for speaking today. I don't think Matt needs any introduction either within the Cleveland Clinic or outside, but we asked him to talk on a topic of his choice, and I think this is going to be a pretty exciting talk. Certainly not something we think about every day, and so I think it'll be a great introduction to some additional tools for thinking about both ventilator and hemodynamic management. So thanks for talking, Matt.
Thanks, Neil. Appreciate it. So today I've elected to talk about practical critical care capnography, and I choose that terminology very deliberately because I want to not get into the clouds, but really focus on things that we can use every day, no matter what kind of setting that we're working in, no matter what kind of questions that we're trying to ask and answer. Obviously, I don't have any conflicts of interest related to anything I'm going to talk about today. There's a couple of devices that will be mentioned, but I'm not making money from anybody. But so first of all, the why. Why are we going to talk about this? Why is this worth investigating? Well, in the first place, there's a multitude of information that you can learn from just observing these waveforms that are just stuck at the bottom of our monitor here. The respiratory therapist throws them on, and we kind of forget that it's there, and kind of just stop paying attention to it. But there's a lot that we can learn about gas exchange, about dead space ventilation, about changes in cardiac output and resuscitation. I'm thinking about hemodynamics. I favor the right ventricle. I think it's kind of more interesting and neglected. Well, CO2 is the same. Everyone wants to talk about oxygenation, but really the CO2 is very important, and neglecting it and neglecting the information it can provide us can be a problem. Time-based capnography and volumetric capnography are not the same thing. I'll discuss both of them. I'll really focus on time today because time is what's most widely available. A lot of the studies or review articles will discuss both, and they kind of conflate them, but they're not the same, and we'll talk about the differences. I'd like to start, though, with a case. This is a 42-year-old man with COVID ARDS. What the blood gas is shown there. His PCO2 is 60, and he's on 50% oxygen with a PaO2 of 80. His vent settings are shown there. His driving pressure is 16, respiratory rate of 28. On lung ultrasound, it's really, there's some findings suggestive of ARDS, but it's not quite as, confluent, very impressive as you might expect. On a focused echo, he's got some RV dysfunction, and he is in 2 pressure shock. With that information in mind, you're looking up at his waveform capnogram, and he's passive on the vent at this point. And this is what the waveform looks like, and this is the value that you get to start with. So this is where I'm going to leave you now. You've got this blood gas, this patient, and this is your end tidal number and your end tidal waveform. And we'll come back to this later. To understand what information we can get from that, we're going to talk about 3 main topics: basics of capnography, traditional uses, and then advanced uses. Starting with the basics, first of all, you have to know what the equipment is and what it's called. There are 2 methods to measure capnography for the most part, either side stream capnography or mainstream capnography. And pointer. All right, so the side stream capnography is what we mainly use in the unit here. So it sends off a long tubing to a module that's external to the vent circuit, and that's why you see this delay that it takes when you, let's say, start to initiate a breath, or you're making changes on the vent. There'll be several seconds of delay. In contrast, the mainstream capnographer that you see here is actually the one off the Zoll monitor that we have on all the code monitors, all the code cards. So that the sensor is actually in line right there with that plastic piece. So the measurement is being taken there, and it's not being sent off in tubing. Practically speaking, the difference is not all that important, except to know that you'll see a bigger delay in the reading with the side stream compared to the mainstream. Now let's just look at the waveform in depth. So this is time-based capnography, which is the same capnography that all of us have on all of our patients in the unit, or at least hopefully have. To go through the steps of the waveform, phase 1 is a combination of inspiration, so there's fresh gas entering and there's no CO2 returning to the sensor. That kind of makes sense. The very end of it, though, is probably the beginning of exhalation, but you don't see it because the initial dead space gas that comes back will be CO2 poor. But then once we start to empty the anatomic dead space and move into the alveolar ventilation, we start to see this upstroke in phase 2. And then where the alveolar ventilation really happens is in this 3rd phase, and at the end of that 3rd phase is where we measure the end tidal CO2. It's just the highest number at the end of the breath, or at the end of the expiration. And the shape of that phase 3 is shape of phase 2 is important. The shape of phase 3 is important. The more angled, let's say the broader the angle is from between 1 and 2, suggests a higher amount of dead space, which could be anatomic or it could be physiologic. And then efficient alveolar ventilation is only happening when phase 3 is rather flat. It won't ever be perfectly flat because as the alveoli keep emptying, the rate of CO2 removal goes up a little bit as the pulmonary blood flow continues throughout expiration. And then we start inspiration, phase 4, and then we're back to where we started again. In some way, you can imagine a universe in which the PaCO2 value is somewhere above the end tidal. There's usually a distance between those two, which represents the different components of dead space. So now let's talk about how we might start to use this information. One of the most obvious uses for waveform capnography is airway management. In fact, the British Journal of Anesthesia guidelines mandate the use of waveform capnography to confirm intubation. You'll find that we've done this to some extent during the COVID pandemic, but prior to that, we were using more colorimetric capnography, which is different. And I will say not only different, but inferior. So why can we not just use this purple yellow thing? Well, if you've insufflated the stomach with a sufficient amount of gas, you can start to return that CO2 back to the color sensor. You won't have a waveform, and you won't really have a good idea of the qualitative nature of that. The same is true for a waveform capnography, but the difference is you will see a decrement in the CO2 level with each additional breath. And by the time you've gotten to 6 breaths, if there's still a waveform present, you're probably in the airway. But if not, then you really need to think twice about it. But the colorimetric device, while it's very convenient and cheap, is not as easy to, it's not as reliable. By the way, I should mention now that you're seeing for the first time on the screen a QR code. All my references that I think are worth you reading, I've included a QR code, so you can either screenshot it, take a picture with your phone, and read the reference that for each individual slide, and these will change throughout the slides. When you use waveform capnography, the sensitivity and specificity for correct airway, correct placement within the trachea is near 100%. Can't get better than this. If you don't have this waveform, then you really need to think twice, because it has been reported to obtain waveform capnography off of cadavers. So if you don't have a waveform, the first thing you should think is, I'm not in the right spot. And then after that, you can start to think about equipment failures and things like that. Another application that's widely accepted for waveform capnography is conscious sedation. This is a much easier way to detect airway obstruction and hypoventilation minutes before your pulse ox will change. Whenever I hear a phrase when I'm rounding in the unit or when I'm overnight in the unit, and a fellow will say something like, there's no way we're going to be able to do this line, this LP, whatever, unless the patient's tubed, then I start to think about doing conscious sedation with waveform capnography. When I'm at main campus, the way that I'll do this is similar to how it's done in the Bronx Suite. Use the same side stream capnography module that we have that plugs into the Philips modules, but then just cut the end of the twist part and place it inside the part that twists onto the ET tube adapter and just stick that through the non-rebreather. It's not quite as accurate, but you'll still get a decent waveform, and most importantly, you'll know when the waveform is absent. At Hillcrest, I have this nasal cannula that actually has a CO2 reservoir and the detector on it. So you see this part here will go, this is both of these tubings are attached to the main nasal cannula tubing. This goes to the oxygen tubing, and this goes to the end tidal module. So a really worrisome waveform that I want you to be aware of when you're providing procedural sedation with capnography is this. So you have initially a very nice expiratory waveform, and then you start to get these smaller and smaller blips, and this person is becoming apneic. Now, I can't tell you whether they're obstructing their airway or whether they're truly hypoventilating from the sedation, but once you start to see this and then it goes flat, you need to start being worried. Or actually, you need to be worried right about here and just keep a close eye on that patient. Sometimes it's simple, they just need a jaw thrust or a chin lift, but sometimes you need to go to an advanced airway. Other essential respiratory applications, things that will apply to a mechanically ventilated patient. One thing we always wonder about, can this replace ABGs or VBGs for the PCO2 value, or can we at least trend it? The answer to that is complicated, and it's complicated because there's differences in, there's a lot of factors that affect the end tidal waveform and the end tidal value. When we look at how well the changes in PaCO2 correlate with the changes in end tidal, you see there's decent correlation there in aggregate. You know, the R is 0.067. That's pretty strong correlation. However, you can see there's some cases where the PaCO2 went up and the end tidal went down. So it's not a perfect measurement. It's something that if you have sort of a steady state condition, as far as you know, it's probably worth trending. But beyond that, you probably need to check in on the CO2 and the pH with a blood gas, and it could be a VBG. You don't need to get an arterial blood gas on everybody, especially if they don't have an arterial line. But just as an example of some of the things that can affect the alveolar ventilation, the magnitude of dead space, VQ heterogeneity throughout the lung, the rate of CO2 production, vent expiratory time, the breathing pattern of the patient, the level of PEEP, changes in cardiac output. So there's a lot of reasons why you may not get reliable, consistent values when you're measuring end tidal and trying to correlate it to PaCO2. Again, if you're in a steady state condition, you're probably all right. But even if you're doing this on a patient with ARDS, you know there's going to be some degree of recruitment or some degree of alveolar collapse, and it's going to affect the way that that the end tidal value is returned to the sensor. What about when we're thinking about optimizing ventilation? When I say ventilation, I really do mean CO2 removal. If we look at this normal waveform that we examined before, if we modify this somewhat, you've seen this version of this waveform before where there's an increased angle on this phase 2 and an increased slope on phase 3. This person is having very, very inefficient ventilation. And there's opportunities here to make changes to the ventilator or to make changes to the underlying patient condition. This type of waveform compared to this could be caused by bronchospasm, other obstruction of the ET tube, or insufficient expiratory time. And you really can't interpret this waveform like you'd interpret this one. The end tidal value will be lower, and you have no idea how efficient the gas exchange is going to be. The end tidal could be lower, but the PCO2 could be rising because your CO2 removal is so inefficient. What this will look like on an actual waveform is something like this. And you've all seen this before, and people talk about the shark fin and automatically associate it with obstructive lung disease. Notice that you have failure to return to baseline here when you enter the inspiratory phase. Again, this is often attributed to bronchospasm or obstructive lung disease, and sometimes it is, but sometimes it's because you haven't allowed a sufficient amount of expiratory time. And the time where I see this most commonly is we have a patient with ARDS who has a low pH. You're trying to allow some permissive hypercapnia, but you're not comfortable with the pHs, so the rate gets cranked up. We don't adjust the inspiratory time or the peak flow, and as a result, you're getting some air trapping. And sometimes the first place you'll detect this is on the end tidal waveform. I see this waveform every day I go into the ICU, at least a few times a day. It's there, it's waiting to be observed. This is a good opportunity for me to mention what kind of optimization I make on the end tidal itself. So when you go into the monitor and when you go up to the monitor in the room, you'll see the end tidal waveform is usually at the bottom of the screen, and then the number is right next to it. If you click on the number, you can change the sweep speed. Basically, your goal here will be to take it from a very short waveform to a longer waveform. The default setting is 6.25 millimeters a second. I usually take it to 12.5 millimeters a second. Sometimes you have to go longer out, even to 25 millimeters per second. And the goal here is just to be able to see how flat the waveform gets in phase 3, because that will really tell you how efficient your alveolar gas exchange is. When we think about hemodynamic applications for end tidal, in this case time-based capnography, there's a number of considerations and a number of applications. First of all, end tidal is in a way related to cardiac output, but changes in the end tidal only reflect cardiac output when that cardiac output is dynamic. If the cardiac output is fairly stable, then what you're seeing in the end tidal is really more of a reflection of gas exchange. The important thing to know about cardiac output and end tidal changes, especially as we're about to talk about CPR, is as the cardiac output drops, the tissues are really good at sequestering CO2 and holding on to CO2 as the cardiac output drops. So as cardiac output increases, you'll expect to see a rise in the end tidal CO2, at least transiently. We've all been through ACLS, and we all understand that CPR, end tidal use during CPR is something that is beneficial. This review that I'm mentioning here in the QR code is fantastic if you want to just understand some more details about CPR and end tidal use. There is decent correlation in CPR in animal models between end tidal and cardiac index, coronary perfusion pressure, and cerebral blood flow. So you can see how this would be something that you would be interested in targeting potentially once you have the end tidal device in line with the patient. As we all know from ACLS, compressions are considered to be of adequate depth and an appropriate rate when the end tidal is above 20. ROSC can be detected when the end tidal waveform jumps. Again, we're thinking about all that CO2 that's been sequestered in the tissues, and now there's a return of circulation, so the number will rise, and usually it should jump by at least 10. Sometimes it's significantly more than that. Sometimes I've noticed 20, 30, 40 sometimes, but that's something to watch as you're performing CPR. Finally, there's a prognostic value of this. If you have end tidals persistently under 10 at 5, 10, 15, and 20 minutes, obviously, unsurprisingly, your survival is plummeting to almost nothing, especially when you get out to the 15 or 20-minute mark. So that's another opportunity to step back and think about what we're really doing and whether it makes sense to continue, depending on what kind of interventions you have to offer the patient. So how do I actually use this in practice? There's always a tendency by critical care professionals, rapid response responders to get an ET tube in the patient as fast as possible. I don't really do that, and that's kind of beyond the scope of this discussion. There's reasons why we should consider maybe waiting on that. So generally what I'll do is I'll have someone place a supraglottic airway just to be able to connect the end tidal, the mainstream end tidal, so that you can monitor the adequacy of CPR and monitor return of spontaneous circulation. This is obviously an opportunity to be able to adjust your resuscitation in terms of CPR adequacy or CPR rate, and in the end, really probably should lead to fewer pauses in CPR. Unless you don't trust the end tidal device, you can probably forego at least some of your pulse checks and then maintain a little bit better of perfusion pressure. Bear in mind with that, though, is there's a tendency, obviously, to use a lot of bicarb in cardiac arrest. Whether we should be or not is also outside the scope of this discussion. But if they're in an ultra low flow state, if any of that bicarb metabolizes to CO2 and still reaches the end tidal sensor, it will make the end tidal jump, and you may have a false reassurance that you have return of spontaneous circulation. So just bear that in mind when you're monitoring this value. Another hemodynamic application that's very interesting and very applicable to us is preload responsiveness. If you have a patient that's passive on the ventilator and you do a passive leg raise and you get a greater than or equal to 5% change in the end tidal value, then you can consider that patient to be preload responsive, to consider that their cardiac output actually rose during this maneuver. The reference study is listed on the QR code here. Interestingly, this was compared to two other measurements. This was compared to changes in just the arterial pulse pressure, which, as we all know, is not that good of a measurement when we look at it on the ROC curve. Here, the area under the curve is probably going to be in the 0.6, 0.7 range. But you see, it just barely does worse than changes in cardiac index. And in this case, the changes were measured by the PICO device, so a calibrated transpulmonary thermodilution device. So really, the performance is pretty decent, all things considered. And this is something you can think of when you have a patient who doesn't meet criteria for other, perhaps more robust measures of preload responsiveness, or if somebody doesn't have an arterial line to measure pulse pressure variation or to use one of our non-invasive cardiac monitors. This would be something that you could consider if the patient is passive with stable ventilation. When we think about advanced respiratory applications, now we need to start considering volumetric capnography. This is a different animal, the complexity is a bit higher, And you'll see the utility that we have described for it is intriguing, but probably limited just based on how limited the devices are. So we have, I think, 2 volumetric capnography monitors in our unit. This is the NICO monitor, which is what we use. It goes in line, it has a sensor that goes in line with the vent circuit, just like another end tidal would be. And the waveform looks somewhat similar, but there are some important differences here. Notice that the x-axis is now considering volume in milliliters rather than time. So we're actually looking at how the volume is coming back to the sensor and what the CO2 content is over time. These phases are pretty similar to the phases of the time-based capnography, but there's no inspiratory phase here. And these slopes and these values mean different things. And we'll talk about them in a little bit more depth here in a second. The benefit of this from a vent titration standpoint is being able to what I would call fractionate the dead space. So when we look at the three alveoli model of the lung, and we know we have A here would represent shunting, B represents sort of an ideal, recruited alveolus with appropriate gas exchange, with appropriate blood supply, and then C is alveolar dead space. When we look at volumetric capnography, we're looking at the total dead space, so the physiologic dead space, which is both the dead space of the airway, which is fixed, and the dead space of the alveoli, which is not fixed. And which is potentially a modifiable target for intervention. So how do you fractionate this information? There are a number of different formulas that you can use in order to gain this information. The NICO device uses the Enghoff calculation, so you actually have to put the PaCO2 into the machine from a blood gas in order to be able to do this calculation. But as you can see, again, we're looking at tidal volume now on the x-axis and not time. So this area here, this area that's represented here represents the airway dead space, and then the alveolar dead space is represented here. So basically, we're taking the area that's inside of this curve right here and using that to calculate the alveolar dead space. Really great review article for which Sheldon Magder is the senior author, which includes this graph and some other graphs. Highly recommend that one in particular. Now, when we think about practically speaking, how does this work? So let's presume that we've given the patient a 390 cc tidal volume and we're not sure how much is doing what. If you have a volumetric capnography attached, you can fractionate this dead space. First of all, we find out what the total dead space is by virtue of the calculation. In this case, the value is 6.62, or that's 62% of what we're giving is dead space, which is alarming, but you'll see it's not really surprising when we consider low tidal volume ventilation in patients with moderate to severe ARDS, which is a lot of what we do. So in this case, the effective alveolar ventilation, which is also measured, basically the difference between the total tidal volume and the physiologic dead space, gives us an effective alveolar volume of only 148. You can see if you drop the tidal volume, how that would really disproportionately affect your minute ventilation, because the dead space fraction would probably rise. If you want to say how much of this is airway and how much of this is alveolar dead space, well, the equation that I just showed you helps you determine that in concert with the waveform and a blood gas. We find out that the fraction of dead space that is possibly modifiable is 17%. And that is something that you could consider as a intervention target from a PEEP titration standpoint, or some other intervention. Let's say prone positioning would be something else that you would expect would have a response from a delta in the alveolar dead space, I should say. And in fact, there are some data to suggest that response to prone positioning, especially in the first few hours, maybe is better measured by changes in PaCO2 and changes in the dead space fraction rather than oxygenation response. And there are some references to support that in the Magder review that I referenced. This is also something that's helpful to know prognostically. Study looking at that question, and particularly just the total physiologic dead space fraction, showed that there is definitely a big uptick in mortality above the 60% dead space fraction. And mortality odds ratio for each increase of 0.1 in dead space increases mortality by 6.8 times using day one values. So this is actually very strongly predictive of mortality. Now, it's never been studied as an intervention target, but you could imagine that if you make interventions to decrease the dead space fraction, you'll probably improve gas exchange, maybe decrease lung strain and stress, and possibly improve the outcome. But this has not really been studied in that way as an intervention. You say, okay, well, this is a lot of really fancy values. What am I really going to do with this information? Well, if you go back to 1975, the Suter paper that I think we all know and love, dead space fraction being lowest at the optimal PEEP is also where the compliance is the best, and also where the cardiac output is the best. So I think the information added here from volumetric capnography is important, but I think it's incremental on top of what we can already do. It's probably a reason not to rush out the volumetric capnography to every patient that we have with ARDS. But you could see there might be certain cases, especially when you're not sure how reliable the measured compliance is. If you have somebody with really high chest wall elastance or something like that, you may want to think twice about traditional measures and maybe use something like this to be able to determine how much alveolar dead space there is and what can you do to actually modify it. So I think that would probably be the best application at the current time with the knowledge that we have about volumetric capnography for ARDS. I will mention, because it comes up in every review paper, that advanced hemodynamic measurements are possible with volumetric capnography, though I'm not sure about the utility of them. And here's a couple of reasons why. They have looked at volumetric capnography as a tool to try to diagnose whether or not pulmonary embolism was present. The measurements and the slopes of the lines that they use to determine whether to rule somebody in or rule somebody out is complex and probably not something that's practically done on a day-to-day basis. So it's something that's definitely not ready for prime time, and maybe someday, if it's can be a little more user-friendly, it would be a better tool. Because obviously, perceiving that there's a increased dead space is something that's still useful, but to go to the extent that some of these studies have done to arrive at that conclusion is really laborious, and things I don't think we're going to really practically do. The other item that comes up a lot is obviously we talked about end tidal being a surrogate for cardiac output in some ways, and volumetric capnography perhaps more so. But this involves, again, increased complexity for probably marginal benefit. Use a partial rebreathing circuit, which is something I'm not even sure we have available to us. And in the end, I'm not sure how much it's really buying you above the other sort of tools that we have to at least estimate cardiac output. So now that we've talked about all that, let's head back to our case. So what struck me about the end tidal particular patient's case was I had somebody that had, moderately severe impairment in gas exchange, but their pulmonary parenchyma didn't look all that bad. Their driving pressure's not through the roof, and there's a huge discrepancy between their end tidal value with a good waveform and their PaCO2. So at that time, we started to think about whether or not there was another reason for the dead space fraction to be increased. And indeed, in this case, we found large bilateral PE with some RV strain, for which this patient received DPA with some improvement in that dead space fraction. And this is just one example of how, without even using the fanciest tools, just detecting that large amount of dead space semi-quantitatively is still worthwhile in terms of understanding your patient's physiology. When I think about end tidal CO2, waveform capnography, whether it's time-based or volume-based, there's a lot of applications that are there that are probably being underutilized. And because time-based is so widely available, I think you really should focus on mastering that as much as possible until volumetric becomes a little bit more user-friendly, widely available, and intuitive. So in the meanwhile, what I would recommend to you all is to stick with the high-yield applications like CPR, intubation, sedation, optimizing your expiratory time, and diagnosing and managing conditions that cause elevated dead space. In case you missed the references throughout this discussion, these are the three that I think are the highest yield. They're all review articles, but they go really into depth and things in a way that is intuitive and also memorable. And thanks to everyone for your attention.